Welcome to AETCM, the emergency medicine channel. Today we will be demonstrating how to reduce a shoulder dislocation. So we will be talking about anterior dislocation of shoulder and how to reduce anterior dislocation of shoulder based on the traction counter traction method or a modified Hippocrates method. So I have a 30-year-old male patient who presented to the to the ER with a fall on an outstretched hand, and he is complaining of pain over the right shoulder. So I am suspecting a shoulder dislocation for this patient. To confirm the shoulder dislocation, we will be taking an X-ray of the shoulder AP lateral. There are several views, but AP view of the X-ray is the most ideal view which can be done. So AP X-ray was taken and it is showing an anterior dislocation of shoulder. Okay, and we are planning to reduce the anterior dislocation of shoulder for this patient. So before reduction, we should take a proper consent of from the patient. We should rule out any fractures in the X-ray. Then we should rule out any neurovascular deficits. Usually axillary nerve will be involved in case of shoulder dislocation. So we should check for the sensation over the lateral aspect of the arm. That is the regimen bat sign should be checked. If at all the sensation of the lateral aspect of the arm is lost, that means axillary nerve is involved. Then we should go ahead with the reduction procedure. So before reduction, we should explain the procedure to the patient and to the bystanders, and we should get their consent. Then we should plan on a procedural sedation, and only after procedural sedation and after giving adequate analgesics to the patient, then only we will be proceeding with the reduction. Okay. Close it. So for our patient, we are having a right side anterior dislocation of shoulder. So before doing the procedure, we should make sure that the shoulder is adequately exposed. So in this patient, we are not, since it's a demonstration, we are not exposing him. So his limb is kept in a abducted and external rotated position. Sometimes patient will be coming holding the affected limb with the opposite hand. So this patient, first we have to apply traction and counter traction. So I will be giving the traction from here, and my colleague will be giving a counter traction with the bed sheet that is surrounding him, and with keeping the other end like this over the opposite shoulder. And I will be giving traction from here. After giving traction, we will be feeling a click. So while giving traction, I will be doing an external rotation, but that time I will be feeling a click. Then after getting the click, I will be doing the adduction and internal rotation, and I will be immobilizing the hand in this position with either a sling or a arm sling or a shoulder immobilizer for at least for 2 weeks. Before discharging the patient from the ER, we should make sure that patient is completely out of the procedural sedation, and a repeat X-ray is taken to rule out any fracture and to confirm that the reduction has happened for this patient. And after 2 weeks, we should advise the patient to review with an orthopedician to rule out any other associated injuries like rotator cuff injuries or something. And we should also advise the patient that there is a risk of recurrent shoulder dislocation, especially with this anterior dislocation. So we should tell the patient not to mobilize the same limb too much. Do not abduct or hyperextend the limb too much. Okay. Thank you.